Hey guys, welcome back to another episode of What Did the Patient Say with Doctors Dana and Lauren Brindisi, sisters and owners of Carolina Functional Neurology Center. We are bringing you inside information from real conversations we have with patients on a daily basis. We get asked the same questions and want to spread the truth on health and healing because we believe everyone deserves to know the answers.
Hi guys, welcome back to another episode of What Did the Patient Say? I'm Dr. Dana and my sister Dr. Lauren. Today we're going to talk to you guys about dizziness. There is a lot of different things that can happen in the brain that can cause dizziness. And we found that a lot of people just get put into a category and then they're given some form of treatment, but it's not actually addressing their underlying issue. So today we're going to kind of break some of those things down and talk about it because dizziness is prevalent and not all dizziness is created equal. And if you guys follow us in any other capacity, we did just put a blog post out last week about this topic as well. So we just want to kind of dive a little bit deeper into that and hopefully answer some questions that you guys may or may not know that you had.
Yeah, so perfect timing for this because I just finished up with a patient who did come in with an acute episode of a peripheral type vertigo. That's called BPPV or benign paroxysmal positional vertigo. This is the one Dr. Dana and I see a lot of people get diagnosed with when it's in fact not what they have. And so we want to kind of break that down a little bit. So with a BPPV, it's really classical, like textbook what's going to happen to somebody. Most of the time, it's affecting the canals in your inner ear, often the ones, your posterior canals or the back canals. So that's usually, I believe the stats about 90% of BPPVs affect those canals. So what's really classical for these patients is they come in and say, every time I tip my head back in the shower, I just start to get really dizzy. The whole room starts spinning and it lasts for a little bit. And it's every time I move my head, especially in a specific position. So then what we're able to do is actually put their head in the plane of that canal. We usually do it with goggles on where we can actually take out fixation and see what's going on with your eyes in the dark. And what will happen is you'll start getting what's called nystagmus, which is just this flowy beat of your eyes, which is our window into seeing that your head, that's vertigo. Why this happens, one of the main theories really is that we have a vestibular apparatus in our ear. There are little canals in there that pick up angular movement of our head. And what happens is the way that those canals work is there's fluid in the canals. And the fluid moves, it pushes these hair cells that then transmit an electrical signal into the brain to say, you're turning your head to the left. It's all it's really there for is to tell our brain where our head is in space when we move around. Well, what can happen is little bits of debris from another part of the vestibular apparatus can pop into these canals and then make the fluid continue to move when it shouldn't. So if it's a classical BPPV, we can actually do a repositioning maneuver where one of the most common ones, it's called an Epley maneuver, where you actually position somebody's head in the plane of this canal and they'll get the very classical episode of vertigo. Usually, there's usually about a 10-second delay and often lasts, maybe 30 seconds to a minute. And then the nystagmus will stop and then we'll turn them in the next position. It'll start again. We'll turn them in the next position and it'll just happen very classically like that. And usually I would say within 1 to 3 Epley maneuvers, just depending on the severity and how long it's been going on, we should be able to totally resolve this.
Yeah.
If
and it should happen quickly. And it should happen relatively quickly. And it should be fixed. And I think the big thing to note on that is BPPV has its own very specific nystagmus. So a lot of people get diagnosed with BPPV, but what helps us is when we put somebody in goggles, we can take out fixations so they don't have anything to look at. we see that because it's got this beat, which is nystagmus, but it also has this rotational component to it, right? And it's following the plane of the canal when we move their head.
Yeah.
So sometimes we put people in that position and they might have nystagmus, right? And they might feel dizzy, but if they don't have that very specific BPPV nystagmus, then we've got to look elsewhere. Like we've got to understand that the vestibular system doesn't stop at the inner ear, and there could be other things going on. And if you're not seeing somebody that truly understands that piece of it, and I think this is where we see a lot of people that get diagnosed with BPPV and they don't actually have it. And what we find, I think, is that we have a lot of patients that end up in our office and they're like, I've been dizzy for years, right? And it kind of comes and goes, right? And what we see is sometimes these consequences of, and sometimes it started as BPPV, right? So 10 years ago, somebody had an episode, right? And they had true vertigo and they had true BPPV, and somebody somewhere along the line did an Epley maneuver on them, and they're like, I feel better. And then they go about their life. And then it becomes this recurring, maybe more chronic thing. And now they're affecting and influencing the way that that vestibular apparatus in the inner ear is now communicating with the brain through the vestibular nuclei. And then we start to see some deficits here. So now people just take that and run with it. And they're like, oh, I've had this before. I'm going to do the Epley maneuver and I'm fine. And then all of a sudden it doesn't work anymore because the issue is no longer in the canal. They don't actually have BPPV, but they might have similar symptoms. Yeah. And they can't figure out why this worked before and why it's not working now.
Yeah. And then we start seeing more like central imbalances in the vestibular system that are like Dr. Dana said, are probably a result of an initial event, but our brain adapts, just like we're always talking about, neuroplasticity and our brain's ability to change and adapt. Well, it changes and adapts for the good and for the bad. And this is a really classical one where now we have to look a little bit deeper at all the areas of the brain that control more of the central aspects of our vestibular system and see if we can peel back some layers of this adaptation over time. And that is kind of that next piece to the puzzle that I feel like we're really successful in helping patients with, because we're just going to look a little bit deeper at those intricacies of the vestibular system within the brainstem and even up into higher cortical regions. The vestibular system is a lot more complex, and it can play a really big role in creating awareness of where we are in space and then where space is in relation to us. And so when the way I describe it to patients is if you've been getting static from this one ear for a really long time, your brain usually says, okay, that's not saying the same thing as your visual system, as your proprioceptive system, and it starts to try to ignore it. So you may feel better, but now you're not getting the same information, and that's when we start to see these mechanisms change centrally, and that shows up in our examination.
Yeah, and by centrally, you're talking about the brain.
Yeah, brainstem, cerebellum.
Those types of areas, whereas a lot of people will just say the vestibular system, and they call it a system, but they kind of cut everybody short at the inner ear.
Yeah, which is really only the start of it. The vestibular apparatus is the end organ to your vestibular system, just like your eyeball is the end organ to your visual system. It's just the beginning place. That allows the sensory information to be transmitted into the brain so that your brain knows what's going on with your head.
I had a wild case back when I first started practice, and we had this patient who was seeing another doctor and then ended up in our office, and she had chronic vertigo. And we would fix it, and she would actually have this rotational BPPV nystagmus, and she would get like a cupulolithiasis where the crystals would stick to this big hair-like structure, so it would get really stuck. So a lot of times when it's the canal issue and you, like you said, you put somebody in that position, it happens, and then it starts to slow down. A lot of times when people have this like cupula involved, we don't see that slow down as easily. So we've got to like shake that loose a little bit.
Yeah.
So we would work with her, and we wouldn't see her for months, and she would develop this, reoccurring BPPV, and we couldn't quite put our finger on it. And I was very new in practice, so I was like, okay, well, let's roll her again. Like it keeps working, and it continued to work for her. So what we uncovered was that she worked, and this was way before everybody worked from home, but she worked from home, and her setup at her computer was she had 2 monitors, and she had one of them in front of her, and then she had one of them off to the side. Now she continued to show this deficit, right, from one side to the other when we evaluated her. And what we learned was all day long, she's typing on her computer, she's doing this. And she's looking at her other screen. So she was creating this imbalance because every time she would move her head, she would look over here and also like spin in her chair. And she's biasing this one side. And we finally figured out, like, oh my gosh, like she just set up for this deficit. She had this BPPV at one point, and it's recurring because what she's doing on a day-to-day basis is perpetuating it. Literally years, this woman. And again, I was new in practice, so now everybody that I talk to, if they work on a monitor, I'm always like, 1 screen or 2 screens or 3 screens, or how are you setting that up, right? But she was just creating her own neurological deficit because of the way her workspace was set up. And so she was constantly putting signal into her vestibular apparatus on one side and never to the other side. So it was pretty wild. Really, so there's a lot of things that can cause it. And I mean, once we fix it, I mean, I still get emails from this woman. She's awesome. She's like, feel great, still good. Like, super cool. I mean,
yeah, that's amazing. So yeah, I mean, your activities of daily living are so important, because yeah, a lot of us do repetitive things or have repetitive postures or movements that could be playing a role. And the other thing that we see, like we're kind of talking about, BPPV is not the only kind of vertigo or dizziness, right? We see this coming from people's necks sometimes, and they feel kind of vertigo-y or dizzy. Of course, we see so many autonomic patients. People feel dizzy when they stand up and change position. That's a different kind of dizzy. Dizzy is very subjective. And sometimes people have a hard time even explaining it, right? Sometimes there's abnormalities in eye movements that are more, related to central brain mechanisms. But what I like to check for people a lot, if they feel dizzy, especially when they're moving their head, right? Where we've got to figure out, is this coming from your ear, from your neck, from your eyes? Those are usually the 3 main culprits. That lagging of the eyes sometimes, I feel like often is coming from people's necks, or sometimes it's coming from multiple regions. And so kind of like we talk about with other conditions, like migraines, where, right, there's multiple buckets that could be affecting. This is the same kind of thing. How can we create lasting change in the patient's symptoms, not just by doing an Epley maneuver, but understanding all the mechanisms of their vestibular system, their visual system, and their spinal stability, to say, and their activities of daily living, to say, are you doing anything that's perpetuating this problem? But how do we make all these systems really stable so they're all telling the same story when you move around?
And they all have to work together, and they all have to send the same signal, right? So
yeah.
If you're translating through space and you're moving your head and you're doing all this stuff, well, you do one of these, and there is an appropriate associated movement or stability that should happen with your eyes. So it's like, if you move your head and that doesn't happen, you're going to feel disoriented, right? Yeah. So you may not feel like spinny. You're also going to be like, I feel dizzy, like something doesn't seem right. And all of these systems in your brain have to be sending the same signal so that you recognize, like, oh yeah, I did just turn my head to the right, and I turned it at this degree, and I turned it at this speed, and everything else, that the signal's coming from my neck because I turned my head, and my eyes are doing what they're supposed to do. So everything is cohesive and sending the same signal. But a lot of times we see the lot of patients that have dizziness, that's not the case. So they get
Yeah.
we kind of call sensory mismatches, where the vestibular input is one sensory input, but then the vestibular or the visual system is another sensory input, and they're not saying the same thing. So then your brain is basically confused about where you are in reference to yourself, but also where you are in reference to things around you.
Yeah. That's a big one, people with issues with convergence, right? So as a thumb comes closer and farther away, we change depth perception all day long. So we need to have this good convergence mechanism where our eyes move in and out. And sometimes if one eye lags or we have an accommodation spasm, that can definitely create dizziness and a ton of other
And
symptoms.
a lot of issues with their cervical spine too.
Yeah. So it's all connected. Yeah. And like Dana said, with the sensory mismatch, sometimes it's like the orchestra doesn't have a conductor and everyone's just doing what they want to do, but not really telling the same story. So when we can pinpoint from all these different areas, then it really bodes best success for actually resolving this issue and not just chalking it up to something that happens to you on a yearly basis just because it's always happened. Right.
Yep. Trying to think if there's other big take homes. And I think a lot of people will look up online how to fix these things. And sometimes if it just resolves, people kind of move on. But I think to your point is making sure that you're having a look at, or somebody that knows what they're doing has a look at it so that they can say like, yes, you did resolve it and you're probably not going to have any residual issues from there. Or, we're seeing some other things and if you feel fine right now, it's kind of up to you, but here are some things that probably need to be addressed so that you don't continue to have the same issue.
Yeah, that's a big one. I feel like a lot of times when I see people who have recurring episodes of vertigo, we usually see other abnormalities centrally in other things. So when they're not having active vertigo, we work on neurological rehab to actually affect their central vestibular system and get the integrity of that up. So hopefully these recurring vertigos become fewer and far between or become less severe or don't come back. And
I think on the flip side to that coin, right? And you and I know have talked about this a couple times where because of our population of patients and we see a lot of these dysautonomias, we've had several patients that come in and they're like, I was diagnosed with POTS, right? So like maybe they had a tachycardic episode, they went, they get this diagnosis and nothing's changing for them. And we've seen a handful of these patients where they actually have a vestibular issue that's creating a lot of their symptomatology. And it's like the way that the brain communicates and stuff, we understand that makes sense. But what's being addressed is actually not the underlying issue. And I actually had a patient today. We did a new patient exam on them yesterday and have that exact same scenario where they're not showing autonomic dysfunction, but they have a massive vestibular issue.
Yeah, I have 3 of those patients right now.
Yeah.
I'm like, you look like you have autonomic dysfunction.
They have so many of the same symptoms, and they may have had dysautonomia or have it, but it may not be what's driving their symptoms right now, right? Because there's no cure. So like you get the diagnosis, you have it, we know it's there, but this flare, this autonomic flare isn't actually an autonomic flare. It's another issue in the brain.
Yeah, which makes a lot of sense, right? Because your vestibular system picks up movement of your head and your body. So when you go and change position, that signal's coming from your ear first, and it fires in through your brainstem right amongst your autonomic system. Okay. So if you're getting like hyperactivity in a sense, and your brain perceives you're moving way more, almost more than you should, not exactly how it works, but or you're having this sensory mismatch and your brain goes, whoa, I don't know where I am. Of course, you're going to spike your sympathetics.
Okay.
Those are really interesting because I feel like when it truly is not autonomic, but an autonomic component is secondary.
Yeah.
These people get better fast with their autonomic symptoms when we can address the underlying vestibular issue. which is a little
But
bit
you
different.
find the root cause, right? Because I think a lot of times people hear dysautonomia and they're like, oh, you have dysautonomia. So then a lot of things just get pinpointed and blamed on that. But if that's not it, then you're just hammering this dead horse. I see that same kind of scenario with some of my like autoimmune patients, like especially MS. You know, it's like your big toenail hurts and it must be like it must be this stamp that you've already been given, you know? So I think a big thing, whether you're dealing with dizziness or any other condition, and you start to see where things maybe aren't responding the way that they have in the past, get a second opinion, get somebody else to look at it in a different capacity, because a lot of times if you just see the same person, sometimes there's, you know, the story gets clouded with like, I have this diagnosis, so we just blame everything on that diagnosis, which isn't always the case, you know? You gotta take it into consideration.
Yeah, sometimes some fresh eyes can be helpful, a second opinion. I always say that to patients. I mean, whether that's, you know, they're seeing, most patients come in seeing many specialists. And if they come in and they're not quite convinced what the one specialist says, I'm like, it never hurts to reach out to a second cardiologist or a second ENT and get another opinion. I mean, you definitely want to work with providers that you trust and that are listening to what you're saying, and are open to say, I'm not quite sure. Let's get a second opinion, right? That's important.
And then the other thing that we didn't even really touch on, and we don't have to go into too much depth, but like autoimmune components to some of these recurrent dizziness, right? Like people have Meniere's disease and there's a host of things that go along, and it's something that you diagnose on evaluation, right? There's no tests, there's no blood work that you can run to say like, yep, you've got Meniere's, right? But that, you know, there's theories out there that is autoimmune driven, and it's autoimmunity to parts of your brain, you know, and there's other symptoms that come along with it, but usually in a lot of cases, people don't get diagnosed with it until it's really bad. Like you have really bad episodes, dizziness, brain in your ear, like hearing loss, right? Like your hearing loss has to be significant at this point to be diagnosed with Meniere's. And I think at some point that's going to get better, right? Like we're going to get better at catching those things maybe earlier, so patients can get better help. But you know, a lot of those patients have recurring bouts of vertigo, right? And so it's like if you see somebody and you can't pinpoint it to something else, that's always something that you want to consider, especially if they also have tinnitus and they have hearing loss. It's all on that same side. You know, if it walks like a duck and it quacks like a duck, you gotta make sure that you investigate.
Yeah. And the other thing is those are pretty classical signs for Meniere's. So I also see people being misdiagnosed with it when they probably have more of a central vestibular issue, and it doesn't really fit the mold for Meniere's. The other one would be Hashimoto's too. You know, patients with thyroid disease, we do see have bouts of vertigo, and it's all about, you know, right, getting down to that root cause. But just because you have Hashimoto's and then you get vertigo doesn't mean it's related to your Hashimoto's. It could be related to something else. So really, you know, uncovering that differential diagnosis and understanding that there could be multiple things involved.
Yep.
All
Awesome.
right.
I think this was a good one. I think this is something that a lot of people deal with, and I think they get stuck in this pattern of just doing the same thing over and over and over again, even if it's maybe not affording them the same response, and they're not necessarily moving forward and feeling better.
Yeah.
So
like we always say, there's other options out there. So and tons of providers that are knowledgeable in this area, and will be able to look at all these different categories for you.
Yep, absolutely. Well, as always, you know, thank you for following us. Thank you for listening. Please like, subscribe, you know, share any of these videos that you think might be helpful for you or for somebody else that may or may not have already listened. And if you guys have other topics, like keep spitting those out to us, because we are listening to you and we're bringing you as much information as we can on all of the things that you guys want to hear about and have questions about. So
thanks for listening. See you soon.
Bye.